Hi, my name is Dr. Lee Zuckerman, and I'm an orthopedic oncologist. And thank you for joining me tonight. I'm going to talk to you about the oncologic indications for both the Precice and Stryde nails, as well as the bone transport nail, and how we can apply the use of this technology in orthopedic oncology. So, there are two different options, and one was traditionally used for growth, which is the Precice and Stryde nails, and then the bone transport nail, which allows for distraction osteogenesis to be performed with an intercalary segment. It works by basically using a magnet, which powers an internal motor and either telescopes the nail or transports a nail down a tract, or the bone down the tract, I should say. And this allows for a non-invasive bone transport that gives you both a biologic reconstruction and allows you to preserve the patient's bone, increase their bone stock, and gives us different options than what we would technically do with traditional reconstruction, particularly if we're using a prosthesis. So how this works, up in the top left corner is basically an example how the patient will hold an external remote controller, which is also seen in the top right picture. And this is held outside the skin, activates the magnet inside the nail, which powers a motor. And for the Precice and Stryde nails, which is shown on the top left and bottom left, it basically helps telescope the nail out. And this can go both antegrade and retrograde, so there is flexibility with this. The bottom right demonstrates the bone transport nail, where you basically have a screw that goes along a tract that again can go antegrade and retrograde and allows for the transport of that intercalary segment with distraction osteogenesis. So what I'm going to start with is basically what I use this technology for in my practice. And the thing that I started with for this was using it for intercalary allograft reconstruction. And that has progressed to treating limb length discrepancies, and that can be with or without a deformity. And that happens from both the treatment of the patient's tumor, as well as complications that occur with both the treatment, chemotherapy, and other issues that the patient may have. I've also used it to treat non-unions, and more recently used it for bone transport. And again, one thing to consider with this is the flexibility, because we can perform both antegrade and retrograde transport, which does help with many of these uses. So the thing to consider is, what are we trying to change or replace? So we're hopefully replacing a lot of metal, because we're looking for a little more of a biologic reconstruction. So that's your intercalary implants and your megaprosthesis. We're also hoping to try to improve the union rate and decrease the complication rate with allograft reconstruction, which has been shown to be better with plate fixation, but can be done with nail fixation, or a combination of both. And then there's also biologic reconstruction, where we use free or vascularized fibulas, and bone transport, which has typically been done with external fixation, which in the tumor world, there are concerns for pin tract infections. These external fixators typically have to be on for a very prolonged period of time, which can be psychologically difficult for the patient, as well as the cosmesis and other issues that we can have from it. So here are just some examples of what we would try to replace or improve upon. On the left is your intercalary replacement. Next to that is a total femoral replacement. This was a growing replacement. In the next to that one is an allograft reconstruction, where both a nail and a plate was used. And then on the right here, we have the spatial frame external fixator, which can be used for limb lengthening as well as deformity correction. So some things we got to worry about is that the literature is really limited in terms of distraction osteogenesis in tumor, and there's very little in the orthopedic literature regarding this. There's actually more in the ENT maxillofacial literature where the mandible's reconstruction with distraction osteogenesis, and they've had very good results. And that includes in patients who've had prior radiation as well as chemotherapy, although they note that the distraction osteogenesis, the regenerate, may be decreased or slowed when it's used in those settings. So when we're doing an intercalary allograft reconstruction, the main reason would be to preserve the joint. And typically we do this in long bone tumors, so femur, tibia, humerus, those are the common sites that we would be using this in. And the studies that are out there, there are a lot of complications with this. And the biggest one that we worry about is non-union. But you can also have a significant risk of fracture of the allograft. They can get infected. They can completely fail, requiring you to remove them. But non-union can range from 15 to 55%. And most of the studies will say that plate fixation is better for this than nail fixation. So again, what's the problem with that? The problem would be how much compression are we able to get across the osteotomy sites? And typically the higher rates of non-union happen with nail fixation, happen when the patients get adjuvant chemotherapy, which is very common in many of our patients, a long allograft, an adult, and a diaphyseal location. So these are things that we got to consider when we're putting in an allograft, and it's possible that the patient may need multiple operations due to the non-union rate. So the advantages to using the Precice nail in this setting would be, first of all, you're avoiding placing screws into the allograft. The allograft is, of course, dead bone. It's not as strong. You're basically putting a stress riser through the allograft. You can crack the allograft when putting screws through it. So these are all things that you got to worry about when you're putting screws through the allograft. The nail is, of course, also load sharing as opposed to load bearing like a plate. So we're not getting any stress risers from that, and we're not getting a stress shielding. And one thing that is definitely an issue with intercalary segments is the bone reabsorption that can occur. And it's possible that this may be due to stress shielding, although many studies say that the ingrowth that we get of these allografts is very minimal, to a millimeter or so. But again, is that because we're causing stress shielding with these plates and not allowing further ingrowth into the allograft from the host bone? The other thing that we can do is recompress in the office. There is some stress relaxation that, of course, occurs with plates and nails after we put them in. And therefore, you can always recompress using the external remote control, so something that's non-invasive in the office if you need to. And then we can also lengthen the limb at a later time. So if the length of the allograft isn't perfect, the patient still has their growth plate, doesn't grow as quickly for whatever reason, or you have to shut down the growth plate, this will allow for correction of that limb length discrepancy at a later time. Now, the technique for this that I've used is basically standard placement of an intramedullary nail with an intercalary segment. So you ream the host bone. The nail has to be pre-lengthened a little bit. Some of the nails come pre-lengthened, but you want to basically match it. And the good thing with that is you don't have to have an exact nail size. There is some flexibility of the length of the nail, but you want to put that in so that you still have some length left to compress. The nail is then put in and try to compress the sites as much as possible, and then can use the magnet basically to compress it further. The nail is straight, so you have to put the nail in to make sure your cuts are perfect or as good as you want them to be. If there's any mismatch, then if it's a large enough mismatch, I'll usually put some cancellous chips or some other sort of allograft. If it's a very small mismatch, something more like demineralized bone matrix, that'll basically fill that gap. And that basically gives you allograft to host bone, just not necessarily with your intercalary allograft, but will decrease any dead space between the host bone and the allograft. And then what I do is intraoperatively, I compress it using the external remote control. And I do it intra-op for a couple reasons. First of all, I want to be sure that that intercalary segment is rotationally stable. And I put my fingernail in those osteotomy sites to make sure that there's no gapping. It can also be to monitor the host bone and the allograft to make sure that no fracture or hardware failure occurs. And this is just something that slow compression and can observe it directly in the operating room to make sure that I'm happy with the amount of compression that I'm getting with this. So let's do a couple of examples of this. This is a 9-year-old male, high-grade pleomorphic sarcoma of the femur, had both neoadjuvant and adjuvant chemotherapy, and had a very long graft length. So preoperatively, you can see the bone destruction of the distal femur. Soft tissue mass is associated there medially. When we get the MRI, we can see that the medullary canal is involved more than just what we see on the X-ray. So this is going to be a pretty distal resection, probably to just before the growth plate. And if you're going to go for 2 to 3 centimeters proximal to that marrow changes, you're going to be in that subtroch region. So it's a pretty long resection. And in some cases, people would say, well, let's do a distal femur or a total femur. If you do a distal femur, there's not going to be much bone left proximally. So if that fails, the patient may end up with a total femur. You could use an allograft with a vascularized fibula. You could use an intercalary allograft, but distally you wouldn't, or excuse me, intercalary prosthesis, but you wouldn't have much bone left distally for that. So in this case, basically do the intercalary allograft with a Precice nail and able to get 2 screws of fixation approximately and 1 screw distally. And the compression allows for rotational stability. So I would not put screws through the allograft, even with just that 1 screw distally, because with compressing of the nail, that's almost making this like a fixed angle device. And that screw is holding that allograft very well. And intra-op, you can feel the rotation stability with this once it's compressed. So over time, the patient healed, and we can see remodeling proximally. Now the question is this bone reabsorption or is this remodeling? I can't say for sure, but if you look on that lateral view, you definitely see what looks like remodeling on that posterior cortex as opposed to reabsorption of the bone graft. So although I have not done any tests to see that this is that we're getting blood flow, I do have this as well as other examples, which we'll show a little bit later on, of how we're getting really more bridging bone as opposed to just the millimeters that might be occurring with plates. So a second example in an adult is a 50-year-old female, isolated renal cell carcinoma, again had both preoperative and postoperative chemotherapy and a decent graft length of 12 centimeters. So on the left, the preoperative image with destruction of the humerus, take that out as a full segment with negative margins, and place the allograft, again compress it. This is a patient who I did compress in the office afterwards because I felt that there might be a little bit of gapping. If you do compress in the office, the patient usually starts to feel a little bit of discomfort when the compression occurs. I've talked to some of my colleagues who do this for trauma or other reasons that are not tumor related, not with an allograft, and they actually look for the screws to bend. I worry that I might be cracking something with either the patient's host bone because of disuse osteopenia or the allograft, and therefore I do not typically do that. But the recompression in the office you can do, and what I've found and what people I've talked to have found is that the patient will experience some discomfort, and that's when you stop, check an x-ray, and that's typically when you'll get good compression. So that distal site on the far right did heal in without a second operation, and we've got good incorporation of the allograft. And again, you can see some remodeling of that allograft to the host bone, as opposed to the basically rectangular shape that we had. It's much smoother, and it looks like there is some bone ingrowth going on there. So this patient I want to bring to demonstrate a couple things. This is an 11-year-old female, osteosarcoma of the femur. Again, pre-op and post-op chemotherapy. This is the longest graft length I've used of 29 centimeters. So the distal site healed perfectly. Proximal site, what I want to emphasize is, first of all, on the left, my reduction is not perfect. Now, there is allograft packed in on that lateral cortex there. So it's not as though there's nothing there. So again, I've packed it, compressed it well, can't get my fingernail into that site. It's packed with allograft that's stuck in there due to the amount of compression that we're getting. Now, what I've also found is, especially in the diaphyseal sites, and usually one site of the allograft, you'll get some bone reabsorption. And in the middle picture, you can see, especially that medial side of the allograft, although we're getting remodeling around it, we're getting some reabsorption of the graft. And this seems to happen around 6 weeks. I can't say exactly if it's due to the amount of compression, if it's due to the remodeling that's occurring, but it doesn't seem to be an issue with this. Now, that picture, as well as on the right, we can see tremendous bridging bone. And in this case, we can definitely say that the vascularization, the ingrowth is definitely going more than just a couple millimeters into that allograft. And this is a great amount of remodeling that's occurring. And this was occurring within 6 to 7 months after surgery. So the advantages of this technique are you don't have to put screws through the allograft. So again, we're avoiding any stress risers. Because we're not using plates, we're not causing stress shielding using the load sharing device. It allows for lengthening through a minimally invasive procedure, which we'll demonstrate a little bit later. And again, we're compressing throughout the entire allograft. Because it's an intramedullary device, we don't have to worry about if our plate is perfectly bent, if it's truly getting compression across all areas of the allograft. Because it's intramedullary, it should be causing compression throughout the entire allograft. The other advantage, or what you could consider an advantage, is that only allograft was used. We're not harvesting a free fibula or vascularized fibula in patients where bone marrow aspiration might be an issue due to metastatic disease. We're not having to worry about doing that to get this to heal. Now, the results of this, originally I had done this with 15 osteotomy sites, and 13 out of the 15, so a total of 87% healed. And 12 of them healed without a second surgery. Average time to union after surgery was 9 months, with a pretty wide range. But the good thing is that for many of these patients, because they have an intramedullary nail, they were able to ambulate, get around, because it's a load sharing device without failure. 2 patients underwent a successful lengthening of 5 and 6 centimeters after developing an acquired limb length discrepancy, and all patients had a negative margin resection with no evidence of local recurrence. The complications that did occur, there was one fracture of the allograft. One of the nail failed, and that occurred with a non-union, which then subsequently healed with an exchange nailing and recompression of the site. And there was one minor complication where a screw, just a locking screw, backed out and had to be removed because it was symptomatic. So this was published in Orthopedics. And of all these patients that were having difficulty with their healing, a little prolonged, initially I did not recompress these. I waited till about 9 or 10 months, and 2 out of the 4 patients who had a in-office compression went on to obtain union. And the 2 non-union sites that remained at the end of this study occurred in one patient who was an elderly patient, long graft, both diaphyseal sites, and had undergone preoperative radiation, with the understanding that none of the other patients had radiation to their sites. So the things that came out of this is basically, what do we know? What do we not know? Of course, we know that allograft is not normal bone, and so that if we're compressing it, we got to be concerned about the risk of fracture. Now, there's also a risk of fracturing the patient's host bone because many times this bone will be weak. And so we got to worry about that. So that, again, is why I'll do the compression intra-op so I can monitor it. The other question is, what weight bearing can we let these patients do? And in the beginning, I was not letting these patients weight bear until I saw some bridging bone. And that's probably the safest method. But these are load sharing devices. The Stryde nail does have certain weight limits that it will support. And so can you let certain patients weight bear right away on this or not? And does that cause too much micro motion or other issues? And those are things that we don't know. And then progressive compression. So in the trauma literature, there are people who will compress routinely after just a couple weeks after surgery. And is this something that we should be doing in tumor? And I have gone a little more to being aggressive with the compression in the office if I'm concerned about if there is any gapping of the osteotomy sites. So in terms of compression, one question that I've been asked is, how much compression are we getting? And we did do a sawbone study on this that compared using the Precice nail versus LC-DCP plate. And we found significantly greater compression that you could get with the nail. So 346 pounds per square inch versus 152 pounds. So you're getting a significant amount of compression with this nail. And that's shown in that top picture with the nails on top with the bright yellow showing the amount of compression that we're getting as compared to the plates in the row below that. The other thing that we found is that we're getting more uniform compression, and that can be seen with the amount of yellow and the distribution compared to the plates below. And these were pre-bent plates, all uniform with the sawbones. So still may not be perfect in terms of the amount of compression, but again, in the clinical setting, you may not be getting perfect compression with your plates. So this shows that just placing a nail ideally gives us more compression and more uniform compression. Question that would come up with this is there such a thing as too much compression? And that unfortunately is an unknown. So the other thing is, can we use this technology to help solve the issues that we get when using allograft? And that includes non-unions. So if we've placed an allograft or we get a non-union, can we help solve that without having to do a vascularized fibula or other treatments? What if we get a limb length discrepancy? And what about if the patient has a deformity? What if we're getting overgrowth or undergrowth of the growth plate? We haven't placed the allograft perfectly and it's in a little varus or valgus. So can we correct these problems? So this is a 21-year-old female, had an osteosarcoma, had prior treatment with a carbon fiber nail and an intercalary implant. Again, a very long graft length. And initially, the proximal site healed very well. The distal site went on to a non-union. We can see the non-union as well as failure of the carbon fiber nail. Those radio-opaque markers should be in line, and you can see the dots have collapsed basically in the distal segment. So what we did is take the carbon fiber nail out. I did not really do much to the osteotomy site other than get it to bleeding bone and add a little more allograft. I did not use autograft or anything else. I did not do a significant recut of that distal segment or the allograft. Place a Precice nail and get good compression across it. And within 3 months, what we're seeing is remodeling of the bone and incorporation of the allograft. So what about a limb length discrepancy? So we're going back to the 9-year-old male that I showed as the first case. He had a growth spurt. His distal femoral physis was shut down by the surgery, and he developed a 6-centimeter limb length discrepancy. So he was off chemotherapy, he was doing well, and 18 months after his index surgery, decided to do a lengthening. So kept the nail in place and basically used drill holes and osteotomes in that proximal segment to do an osteotomy. I still went through the normal bone, even though it looks like that proximal bone of the allograft is incorporated and has good vascularization. I'm not going to assume that. I'm going to go through an area where I know there is healthy bone, and then slowly distract the patient at 1 millimeter a day. For the femur, I typically do 1 millimeter a day and divide it into 3 sessions, and we're getting good regenerate there. And at final follow-up, we can see telescoping of the rod on the right, and very good regenerate with remodeling on the left there. So again, good vascularization, correct a limb length discrepancy with 1 implant, and a good amount of versatility that we can have with this for a biologic reconstruction. So this is an example of a 31-year-old female, chondrosarcoma, who underwent a hemipelvectomy and a hip fusion to the pubic rami. She developed a 5-centimeter limb length discrepancy, had to wear a custom shoe, and she underwent a proximal femoral osteotomy and lengthening. And this is pretty common for those of us who are not reconstructing the pelvis. This patient had difficulty walking, especially when she was at home and was not using her custom shoe, had a lot of back pain, contralateral hip pain. And we can see here that she was placed in a little bit of adduction, and actually developed a pseudarthrosis of her pubic rami, which did allow her for a little more range of motion there. So underwent a proximal femoral osteotomy to recorrect the adduction and make her leg a little bit more anatomic. And then a Precice nail was placed in a retrograde fashion, and the patient underwent lengthening with demonstration on the far right after the nail had been removed with good regenerate. And we can see here the pre and post-op with correction of both the adduction as well as the limb length discrepancy. So this patient is now ambulating with regular shoes, having decreased pain, and it's really life-changing in a situation like this. So this is something that is a very common issue when the pelvis is not reconstructed, that we can correct pretty easily. So what about the case where we have a limb length discrepancy as well as a deformity? So this is a 13-year-old female, had a Ewing sarcoma, had an intercalary reconstruction 6 years prior with a plate, and developed a limb length discrepancy, but also a valgus and procurvatum deformity. And this was just with plate fixation, and that proximal site healed extremely well. The distal site was clinically healed and intraoperatively was healed, but took a longer time to heal in this case. But we can see there a valgus deformity as well as procurvatum. And she basically had a significant scissoring gait with this, and really had a lot of difficulty. So in this case, take out the plate, placed a blocking screw to help get the alignment correct on both the AP and lateral, and placed a Precice nail that bridged across all the other prior screws through the allograft as well as the patient's host bone. Now, in the literature, this type of correction is described with using blocking screws as well as a temporary external fixator. In this case, due to the allograft bone and the minimal bone proximally and distally, did not use an external fixator, but that may help if it's possible to get your deformity correction better. But we can see in this case, both the valgus and procurvatum deformity are improved. And this is during transport, and we can see on the left the significant valgus deformity as well as that limb length discrepancy. And on the right, leg has been straightened out and she's undergoing transport. And at the end of transport, we can see good regenerate, again, distal to that allograft. We've got better incorporation of that allograft, which is likely due to either stimulation with the nail and the reamings. But overall, good result, and the patient now has symmetric leg lengths and does not have the deformity. Now, what about the case where we know that we're going to shut down the growth plate, but the patient doesn't necessarily have a limb length discrepancy at this time. What can we do in these cases? We could shut down the contralateral growth plate and try and estimate when we should do that in order to obtain symmetric leg lengths. So how about bone transport? Now, this is an evolving technology. This is, again, very limited in the orthopedic literature. It's been done with external fixators and typically not when the patient is on any chemotherapy. So I performed this procedure on 6 patients with a wide age range, average of 51, but as young as 16 and as old as 70. Mostly male, mostly femurs, and so far I've had decent follow-up, but again, this is all short-term follow-up. And we can see that the diagnosis included mostly metastatic disease with one high-grade osteosarc, but otherwise metastatic disease that was isolated, and the patient had shown good responses to their chemotherapy regimen. So you can see they had a wide range of adjuvant therapies after the surgery. The osteosarcoma patient is the one that had the cytotoxic chemotherapy. Otherwise, we're seeing a lot of immunotherapy as well as denosumab. And the concern may come up is, what do we do with denosumab? And if you look at the literature, bisphosphonates have been studied with Regenerate, but not denosumab. And the studies out there actually say that bisphosphonates can be used as a rescue for Regenerate, so actually increases the amount of Regenerate you get. So in my 6 cases, I've noticed that the patients on denosumab do seem to have an increased rate of Regenerate, and I've actually had to speed up some of their transport due to this. The cytotoxic chemotherapy is traditionally felt to cause problems with the Regenerate, although there's very limited clinical studies about what happens with this. But the in vitro studies say it causes problems, and I'll show you the case of the osteosarcoma in a minute. So again, what we're doing is a standard resection with negative margins. If we do not have negative margins, we're going to have a problem. The other concern is, well, with this distraction osteogenesis, especially in the patient with the osteosarcoma, there's a theoretical concern that we're going to cause tumor growth or proliferation. And there's no study out there that says that this happens. I've looked at it in the way that I have had patients where I've placed a replacement and the bone has started to crack and that's healed without causing a recurrence. And I've had patients who've fallen and broken another bone and they have not developed a sarcoma in that site. So there's nothing in the literature regarding this, but this is a theoretical concern of it. So we had 1 case of an acute shortening followed by a lengthening, 3 cases of what's called plate-assisted bone segment transport, and I'll show that in a minute, and 2 cases utilizing a bone transport nail. I did not delay any chemotherapy to start this transport. It started 1 to 2 weeks after surgery. And for the femur, I went 1 millimeter a day. For the humerus and tibia, I went 0.75 millimeters per day. So when I do this technique, I do bone graft the defect, and I'll do that for a couple reasons. One is in especially long transport where I may be going past the capacity of the nail. I'll bone graft it. It's also to hopefully save the patient a second surgery or preparation of the docking site. The other reason I've used it is to increase the patient's bone stock if a very distal or proximal resection has been performed. And I've been calling this the transplanted membrane technique. I use an acellular dermal matrix. I've used alloderm for this, and I'm basically suturing that to the surrounding tissues and around the nail. So I'm not attaching it to the actual bone. I'm basically making a tube that the segment can transport through. And what I put in there is allograft. I'll use cancellous chips, demineralized bone matrix, and I have used autograft in this case. But basically, this is something where I'm able to contain the bone graft, and it's actually getting compressed during the transport. It also keeps open the transport site and hopefully prevents the patient from needing a second procedure for either exchange nailing for a very long transport or to prepare the docking site. This is an example of a distal femur, which we'll see with the patient in a minute or two. But this is in order to reconstruct the bone stock in the distal femur. So again, the alloderm with the bone graft in place there. So this is an example of an acute shortening. And this can be pretty limited of when we can do this. But in this case, the patient had a pretty short segment of tumor there that was resected. 60-year-old, had isolated metastatic renal cell, and basically shortened the humerus at that time. Don't have to get this perfectly opposed, because usually we're lengthening this a millimeter or two at the time of surgery if we are doing a transport. So you can see in that second image that it's not exactly next to each other, but within good enough proximity. And then slowly expanded the patient. The patient was getting adjuvant chemotherapy, and on the far right, good regenerate noted, and restoring the limb length in this case. Now, this is an example of plate-assisted bone segment transport. So this is something that you would use with the Precice or the Stryde nail, because it won't go proximal and distal to your osteotomy sites with your segment that you're transporting. So you bridge this with a plate. So the plate is basically bridging from that proximal femur all the way to that distal femur. The Precice nail is in that intercalary segment, and this is a retrograde transport. So you can see the rod is telescoped out, and we're going to slowly bring that up. Now, a technical note, if I wanted to do a longer transport, I would have the Precice nail end at the more proximal portion of that intercalary segment. So I would be using a shorter nail, still expanded out all the way. But what that will allow is that once that bone has been transported as far as the nail can go, I can then take out those distal locking screws, reset the nail, re-expand it basically, put in the distal locking screws again into the more distal aspect of that allograft, and then transport it further up. Now, this patient does have the bone graft with the transplanted membrane technique in there, and you can sort of see that in the third picture. But in the fourth picture there, we can see more of that bone graft at the initial time of compression. That fifth picture, we're seeing great regenerate and remodeling going on there. And in that final picture on the right, we do have remodeling and bridging of the bone graft. And I did do a CAT scan, and there was bridging bone in this case. So this is for the bone transport nail. And the advantage to this is that we don't have to worry about putting a plate on. So this was a 69-year-old male, again, isolated renal cell carcinoma, and have 11-month follow-up on this patient. So a pretty large segment, approximately 18-centimeter defect that was caused by resection of the tumor. Made an osteotomy as proximal as possible with that normal bone and the intercalary segment. Because it was such a long transport, again, I did the transplanted membrane technique and put the bone graft in there. And this patient was on denosumab, and he actually had such great regenerate, I had to increase his rate to 1.33 millimeters a day because he was healing too quickly. And it's good to follow these patients every 2 to 3 weeks. Monitor what's happening with them. If they're having any pain or discomfort with the transport, they should get checked. In this case, he was having some pain, and that was because the regenerate was starting to consolidate too quickly. So sped up the rate, the pain went away, and it was able to continue the transport. But if you're not monitoring these patients closely, you may have too much regenerate or too little regenerate, and it's good to adjust the rate that you're transporting the patient to the individual. So at most recent follow-up, we can see just tremendous regenerate proximally over a long segment. The distal bone graft, again, is consolidating and does have some bridging bones. So that looks like it's starting to work, although it still remains to be seen if that's going to fully heal in and remodel, as I'm hoping it will be. But otherwise, that doesn't have to be done. We could say, well, we're going to continue to transport, get it down there to dock, do a docking procedure, which can be either scraping up the bone through a small incision and putting in some bone graft. Some people do it percutaneously with a bone marrow aspirate. So there are options for this. But since the patient is on chemotherapy, they're getting around and walking, have no pain. They have no pain at the osteotomy sites. I'm allowing him to just continue with his chemotherapy and not stop any treatment for any surgery. So this is a more extreme example. This is a 16-year-old male with the high-grade osteosarcoma of the distal femur. His physis prevented the growth into the epiphysis. So a pretty short segment overall. It was about a 7-centimeter defect. The nail was able to get 2 screws into that distal site. And again, I used that transplanted membrane technique, and that was the picture of the distal femur that I showed earlier. And he underwent transport. He unfortunately was unable to get into a clinic for follow-up, and so his regenerate was not as good. If I had seen him in the clinic, I most likely would have slowed his regenerate or stopped him for a little bit of time. Again, he was undergoing the cytotoxic chemotherapy, so that's the one that we worry about how the regenerate is going to do. The other thing that occurred, which is a little hard to see, but if you compare the third picture from the left with the initial distal segment versus the far right, we can see that there's a little bit of back out of the screw as well as nail migration. The patient continued to transport even though they started to develop a little bit of pain. So even though I instructed him to stop transporting if he had any pain, he did transport for about 4 to 5 days after having pain. And what this is likely due is the compression of that transport segment against the distal piece that's causing the nail to cut out a little bit. But the nail did not fail and decided to monitor it. Now, one interesting thing with him is on the left, you can see at the end of transport, his regenerate, the APN lateral there, is very, very poor. And this is while he's on chemotherapy. Now, about 6 weeks after he stopped chemotherapy, we get the pictures on the right. So the regenerate has significantly improved, and I'm continuing to monitor this. But that does provide hope that once the patient is off chemotherapy, that the regenerate that's formed is going to improve over time with this. So overall, we still have bridging bone there, and that hopefully is going to continue to remodel over time. Distally, we can see with the bone graft that that's consolidating and compressed pretty well, and it looks like we're getting a little remodeling, a little more normal appearance to that distal femur, and that will hopefully help prevent any fracture or any other issue as we get more forces in remodeling of the bone over time. But overall, looks good. That it looks like that allograft is healing to the transport segment and incorporating well. So with this, I've done it for an average defect of 10.7 centimeters, and that includes the acute shortening. It's 12 centimeters if we only use the bone segment transport cases. Early results, small series, but no early infections, no recurrences, no wound complications. As we saw in that last case, we had a partial back out of one of the screw with nail migration. 3 of the patients did undergo a secondary planned procedure, 2 for screw exchange and 2 to reset the nail. So the screw exchange is something that's necessary with the bone transport nail if you want to do a long transport. It basically has a window where you take out that intercalary screw and have to move it to a second window if you're undergoing a long transport, and that's a thing that has to do with the strength of the nail. I plan this out, so depending on how long the transport and the rate I'm going and their chemotherapy schedule, I plan out for that screw so that that can be done without interrupting their chemotherapy. It's done through a small percutaneous incision, so I have not delayed the patient's chemotherapy for such a small procedure. And then the resetting the nail would be an example of a segment with the plate-assisted bone segment transport, where you can reset the nail in order to get a longer transport. So overall, we've had no real issues with the regenerate. The regenerate was very poor on that osteosarcoma case, but is continuing to improve over time. Again, with the denosumab patients, we seem to be getting a lot better regenerate, but these are limited numbers. So this is something, again, should monitor these patients every 2 to 3 weeks at most to see how their transport is going and see how their regenerate is going, and change that if necessary. The things that we got to look at in the future for this are, what's the functionality? Is this going to be better for the patient? Is it going to last long term? Does the bone grafting work versus doing a docking procedure? And again, that is putting the patient through multiple procedures early on in their course, which can cause problems with their chemotherapy. So again, I've been trying to avoid causing any delay in their chemotherapy with the bone grafting, but is that going to work? And then will that docking site heal? And that again is, how well is that going to heal? We've seen good regenerate overall, but how well is that docking site going to heal if they're still on chemotherapy? The good thing, though, is that with this technology, we have multiple reconstruction options. So we can use allograft. We can solve a lot of the problems we have with allograft. We can perform bone transport non-invasively, so that we do not have to worry about pin tracks and other issues with that. And again, we can correct a lot of the complications that we have due to tumor surgery, such as non-union, limb and other issues. So this is something that with this technology, I believe that we should really consider this as an option when we're considering a biologic reconstruction for the patient. And that ends the presentation. Thank you all for listening. If you have any questions now, we'll go to that. And thank you again for taking the time to listen.